and webinars, of course. Allow me here to thank all the members of this task force who really work hard in order to organize and prepare everything and make sure that everything is running smoothly. So thank you, Blaženka, Rafaela, Dorina, and Raluca, Jessica, and also Tomislav. Thank you so much for all your work. Every year, on the 6th of March, the European Speech and Language Therapy Association, ESLA, celebrates the European Day of Speech and Language Therapy, as this day marks the anniversary of the founding of this Europe-wide organization. On this day, speech and language therapists across Europe come together to organize workshops, training, media coverage, and conferences. This year's theme is Speech and Language Therapist Role in Critical Care and Emergency Medicine. So allow me to share with you today's agenda so you can, so that you know what's going to happen, and then obviously we will run through it. So I'm going to share my screen. Here we go. So as you can see, we started with some introductions, and we will be having some announcements as well. Then we will have a short welcome address by Ms. Norma Camilleri, ESLA Chair, and then we will be having our webinar presentation by our guest speaker, Dr. Jackie McRae, and finally, we will be having some closing remarks. May I remind you some house rules before we move on? Kindly keep your cameras switched off and your mics muted. If you have any questions, kindly use the chat option in the Zoom, and these will be tackled later on after the presentation is finished. And I would also like to welcome those following us on live stream Facebook. So may I also remind you, yes, because my colleagues are also reminding me that towards the middle of the presentation, we will be sharing an evaluation form, a link on chat. We really appreciate that you fill in this evaluation form because we really value your feedback, but also if you would like to receive a certificate of attendance, you also need to fill in this evaluation form. So stay on the lookout to fill in this link from the chat option. So some exciting announcements. So as you can see, our task force is very busy preparing preparing the next webinars. So please take note of the following dates, which are June 22nd, October 5th, and November 30th, on which we will be having 3 different speakers. In June, we will be having Professor Dr. Roel Williams from the Netherlands, and we will be talking about narratives as a window onto the mind. On October 5th, we will be having our colleague, Dr. Mark Jays from the Manchester Metropolitan University, and we will be talking about the SLT role in supported decision-making and mental capacity assessment. And then in November, we will be having Emeritus Professor Edith A. Strand from Mayo College of Medicine, and we will be tapping into childhood apraxia of speech differential diagnosis. So have a look at these dates. Later on, at the end, we will be sharing this slide again for those who maybe missed the first part. So on to the next very exciting announcement. So ESLA is inviting you all to join us in Belgium for the 12th ESLA Congress of Speech and Language Therapy. The dates are still not yet confirmed, but it's going to happen around September, October of next year, 2024 in Belgium. Please stay on the lookout for more details as these are coming up, and you can look them up on eslacongress.eu as well on ESLA's social platforms, Facebook, Instagram, and also Twitter. So without further ado, I'm going to leave the mic to our ESLA chair, Ms. Norma Camilleri, who's going to give us her short welcome address. Thank you, Norma. I'm going to stop sharing right now.
Good morning, everyone. Buena dia. Buongiorno. Good morning. I can see it's bonjour to my Maltese fellow colleagues. It is wonderful to see such a varied participation from all over Europe joining us this morning. Thank you so much for being here with us. And thank you also to those who are following us on live streaming. It is an honor for us to have Dr. Jackie McRae with us this morning to talk to us about the theme that we chose for this year's SLT Day. As Daniela said, we celebrate the anniversary of ESLA on the 6th of March, which was born in 1988. And I take the opportunity here to thank all the past presidents and all the past members of the various boards that led at the time CIPLOL and now ESLA. As you know, the organization underwent heavy restructuring, and the aim was to make sure that we are closer to the needs of our members and to the needs of our profession in the whole of Europe. As you can imagine, in 35 years, because we are celebrating 35 years of this European organization, our profession grew and the needs grew and the needs changed. And so it was very important that the organization also changes to be able to see to the needs of our profession. We believe that it is very important to work on the standards of our profession, not only to safeguard our profession and ourselves as professionals, but also to safeguard our clients, all the clients who receive therapy because of communication and or swallowing disorders. It is a challenge for our organization to see to the needs of all the different countries, because the situation of our profession varies so much in all of Europe with regards to recognition, regulation, initial training, the standards of practice, and so on. So it is a challenge which we took on very seriously, and we believe that it is important for ESLA to be there for all. It's not just the member countries, but for all of Europe, and which is why our vision is to be the authoritative voice of speech and language therapy in Europe. But this cannot happen without the involvement of our members and of you all who are members of our member associations. So I strongly encourage you all that if you are members of member organizations of ESLA, to support your organization. And if you are not a member of a member organization, I invite you to join your local association, because it is very important that we all belong to a professional body. And if we all work together, then definitely we can bring about a change. A lot of speech language therapists around Europe find it challenging that in spite of all the work that they do, in spite of all the work that we do, we are still considered on different levels when compared to other professionals who might be doing more or less the same work that we are doing, but the status is different. And obviously we are human beings, and so obviously that is something that puts us down and it is important that we elevate the standards of our profession and that we increase the awareness with policymakers, with authorities, other professionals, to show what our role is in the different areas that affect communication and swallowing disorders. And which is why ESLA plans also to set up task forces to work on different guidelines on how to use on our role in different disorders, and even perhaps in the use of different tools, which in certain countries other professionals feel that it is only their duty to be able to use those tools, such as FEES and tracheostomy care, which we will be, I'm sure we will be hearing much more about that today. So ESLA wants to give more credit to our profession on a European level, and which is why we are striving to be closer to policymakers, even on an EU level. Obviously, we are there for the whole of Europe, but we are aware that since the majority of countries are within the EU, that is the place where we also need to concentrate some of our energy. And which is why we constantly are on the lookout to make sure that the whole of Europe is on the map of ESLA, and we constantly seek and approach other associations to join ESLA. So as members of ESLA, those of you who are members of our member organizations, I strongly encourage you to look out for any call we have for the various task forces or different teams we have, because you as members of an ESLA member organization are entitled to be part of these task forces. So all you have to do when you see one of these calls, you just need to approach your association and just ask them to help you out with your own nomination. And I can assure you that it is a wonderful networking opportunity to meet with other colleagues from all over Europe. We just had a 2-day intense meetings, actually here in Malta, for the Common Training Framework Task Force. And work is proceeding very, very smoothly, and it is, I can say, moving quite ahead now. And this is a very important piece of work because it aims at setting the standard for the minimum level of training for initial training for speech language therapists across Europe. As you know, we had done 10 years ago, we had carried out the NetQuest project, and if any of you are interested in looking into it, you can find it on the website. I will put the link on the chat later on. And this project came up with mapped the competencies for the initial training for those of you who are perhaps involved in planning programs for speech language therapy. I strongly encourage you to visit this document because there is a lot of very important information and interesting findings. I know it might be a bit outdated now because it was 10 years ago, but which is why we are furthering work on that project. So I would like, Daniela thanked all the task force members, but I would like to thank Daniela for her hard work in leading this task force, which is an important task force for us, as all the other task forces. So I thank you all for your attendance and participation today, and I strongly encourage you to spread the word about ESLA and about the work that we're doing, and invite you to join us in other events or in the different task forces whenever you can. Thank you.
Thank you so much, Norma, for your message, and I cannot agree more with what you said, because yes, being in a task force, it is really and truly a learning experience. So let me just share my screen once more so that I can present our guest speaker for today. Thank you, Dr. Jackie McRae, for accepting our invitation and be here with us today. Dr. Jackie McRae is a clinical academic speech and language therapist with over 30 years experience working with adults with complex acquired dysphagia in specialist and general critical care units in and around London. She has worked with cardiothoracic, transplant, neurosurgical, spinal cord injury, and more recently, COVID patients. So, Dr. McRae, I leave it up to you, and we are all very excited to hear your presentation. Thank you.
Thank you so much. And I will just share my screen. Lovely. Can you see that?
Yes, we can see.
Thank you, and good morning to all my colleagues in Europe and around the world. A huge thank you to the ESLA committee and Blaženka, Norma and Daniela for inviting me to present today on the role of speech and language therapists in critical care and emergency medicine. This is a photograph of myself and a colleague, Orna, in the depths of COVID. We were delivering our service on ICU. You can see our FEES equipment to make a real difference to our patients' lives. We know how important our role is, but my question is, does everybody else? And so I'd like to really carry on the theme that Norma's introduced around empowering you to get involved and to make a difference with your services. As you know, this on Monday and this week was a celebration of speech and language therapists across Europe and across the world, and absolutely privileged to be invited today. I'd like to introduce the concept of a new superhero, and that is going to be our critical care advanced practice speech and language therapist. And I think we really need to celebrate the role and our contribution in this environment. There are so many colleagues that I've worked with from around the world. This is just a sample of those that I want to say hello and say well done. And there are many, many people behind each of these. They're all superheroes. And I want to be able to cover slide after slide with all your photos to say thank you to you. My aim today is to take you through a bit of a historical perspective of our role in ICU from my own experience in the UK, and consider the need for speech and language therapists in that environment, how we can direct our clinical management, and I'm going to leave you with ideas for you to plan your own action in your own countries. It's a really exciting time of change, and I was delighted to see on Monday groups from the Netherlands and Sweden promoting the change in their role in ICU, and definitely this is something for us to continue to build on. So back to my own history, I graduated in 1991 and started working in a mixed pediatric and adult post, which included working at Papworth Hospital, which is a very well-known cardiothoracic and transplant hospital. I was delivering mostly post-acute rehabilitation, focused on communication and swallowing impairments. Some of these patients probably had a stroke after their surgery, and some had retained some neurological impairments and had a tracheostomy. In those days, we didn't have a whole host of tools to use. It was mostly a bedside swallowing evaluation and video fluoroscopy, and maybe just at the end when the tracheostomy was coming out. I worked very closely with our physiotherapists and the other clinicians to really problem solve what was going on. We didn't have Google in those days. Thickened fluids was probably a mainstay, and we used it a lot, as well as swallowing maneuvers. And then when I moved to work at Barts, St Bartholomew's Hospital and Charing Cross Hospital, that was mostly with neurosurgical patients, again working very closely with the other allied health professionals to support rehabilitation for communication and swallowing. In those first 10 years, I would say that speech and language therapists were usually reluctantly invited onto ICU, usually after the team had tried some other way to solve their problem. And so we were very much outsiders to that environment. Moving on to the next 10 years, I briefly did a time in the community rehabilitation, and although I enjoyed it, I really missed that acute environment. So I moved back into the Royal National Orthopaedic Hospital and took on a role that involved seeing patients with spinal cord injury. And at that time, there wasn't very much information at all. But they were clearly very complex impairments. And I was fortunate to be a key member of the tracheostomy team. And this meant that we would review our patients on a weekly basis in terms of their respiratory function, nutrition, tracheostomy status, their ventilators, medication, quality of life, their tracheostomy wounds, everything. And then when I trained to use flexible nasendoscopy and FEES, we integrated that as part of our tracheostomy team decision making, and it made a big difference to the decisions we made around tracheostomy and ventilator weaning for our patients. As you can see, I was able to grow my own autonomy, and that's what we were seeing across the profession. There was true interdisciplinary working, and we would have to consider a range of swallow interventions to overcome the very complex dysphagia impairments associated with these injuries and the need for tracheostomy. In contrast, I was doing some work at Harefield Hospital, and I found that there the speech and language therapist had a much smaller contribution because the physiotherapists and the doctors took the lead. And I think one of the key issues is around workforce, in that speech and language therapists often work less than full time, and so they can't be dedicated to deliver a service. So at the end of 2012 and 2013, after seeing such a huge gap in the evidence, I undertook my PhD in the management of dysphagia in acute spinal cord injury. And I proposed a team approach advocating for early dysphagia intervention and treatment after seeing firsthand the positive impact of my own interventions with our patients who were thought to have intractable dysphagia, but yet we could then get them back onto oral intake and indeed verbal communication, even if they were ventilated. So again, I proposed really early intervention, multidisciplinary working. After my PhD, I moved to the 1,000-bedded St George's Hospital, which is a big major trauma centre with its own 3 different intensive care units. And there I led the service developments with our speech and language therapy team, and again integrated our involvement in each of those ICUs. I also took on an academic role part-time, which I still undertake now, and that helps to maintain my research alongside clinical practice. As Norma suggested, I was able to be involved in our professional body's development of critical care guidance for other speech and language therapists. So really trying to influence what our whole profession is doing. And this is just a screenshot of the web pages that we developed for people working in critical care. I've also been involved in the Intensive Care Society development of a career development framework specifically for speech and language therapists. So this maps out the skills that are needed at different levels of your competency. And it's a really worthwhile document for you to have a look at and is available online. I've also been involved in writing the guidance for the use of FEES, particularly during the COVID pandemic. And I've written a number of papers trying to raise awareness of the role of speech and language therapists in intensive care. And a few years ago, I pulled together a group of colleagues and we wrote an article, wrote a chapter in this book around the power of communication as part of ICU. And we're just revisiting that following the COVID pandemic. So there's lots of potential involvement for each of you, and I would really encourage you to do so. Back to my own history. So 2020, I moved to UCLH to upskill their team into ICU. And then, of course, in March 2020, the pandemic hit. I was invited, in fact, I was asked to join the Allied Health Rehab team at our makeshift emergency hospital, NHS Nightingale. This was a tough time. I had to say goodbye to my family and pack a suitcase to stay in a hotel. But although it was quite worrying, my family knew that my work could make a difference, and it was an absolute honour to be invited to be part of the fastest change project our health service has ever seen. After spending around 6 weeks there, I went back to UCLH, which had become a dedicated COVID centre, and we were actively involved in decisions for weaning from ventilator, tracheostomy, and problem solving some of the very complex airways that we saw. And for almost all of our patients, they were able to return to speech and swallowing. At the end of 2021, I took on a clinical transformation project, which I'm just doing at the moment, which is transforming care for our spinal cord injury patients. That's my real passion, really growing the evidence to support our rehabilitation with these very complex patients. Alongside that, I deliver teaching to advance clinical practice, not just for speech and language therapists. I lecture to physiotherapists, occupational therapists, nurses and paramedics as well. But I think there's a real role for speech and language therapists advancing into ICU, and I would call that advanced practice. Of course, COVID brought many challenges, but there were also opportunities to collaborate. And again, like Norma has said, I think these are fantastic for you to reach out to international colleagues to be able to compare our role and our caseload and really understand how we can navigate forward with our skills. We looked at aspects of dysphagia and dysphonia, mouth care, and really trying to provide a cohesive response to COVID. So coming back to critical care, how did we get so involved? I remember over 30 years ago how dramatically different this critical care environment was. Our patients used to all be sedated and bedbound with fairly limited survival for those with complex conditions. Usually the patients I had to see were sitting up in bed, very easy. But we now have rehabilitation happening in the ICU, really exciting. So many of our patients who would have died many years ago are being kept alive. This is due to the advanced healthcare technologies that are used by our paramedics and in our ICU. But keeping someone alive is not the same as letting them live a life of good quality. So this is the space for high quality, effective rehabilitation. It helps the patients, but also it helps the hospital administrators in terms of length of stay, which saves money, reduce complications, which saves money, and also speech and language therapists are a lot cheaper than some of our other colleagues. So my case is, why not invest in an expert speech and language therapy workforce for ICU and bring in your superheroes? So how did we get here, really? We were fortunate in the UK, there is national guidance, and back in 2009, it was fairly generic, but it did say that our patients need rehabilitation while they're in intensive care. Another document in 2014 made specific recommendations that speech and language therapists should be involved in tracheostomy patients. And the intensive care followed that up with their own documentation. And in 2019, they specified the staffing levels for speech and language therapists. Only last year, national guidance for rehabilitation after traumatic injury was published, and we're going to look at the details now. This was a real game changer for us, the setting up or the establishment of quality standards for rehabilitation after critical illness. And this shows that there is a requirement for critical care to be responsible for setting rehabilitation goals and delivering those goals even after the patient leaves ICU. So they have an individual rehab program, they are required to be given information, and even after they leave the hospital, they will need to be reviewed by the team after critical care. So they are accountable for whatever happens in critical care for a long time afterwards. This means that we have documentation and that data is submitted to a national database. I mentioned the Intensive Care Society guidance, and their standards were that all patients with a tracheostomy must be seen by speech and language therapists. So, and this means that we have a permission to go there. They also would like speech and language therapists 5 days a week. So this is a highly ambitious goal, but important to state that. When you look at the detail, they are proposing a minimum staffing level of 1 speech and language therapist for every 10 beds. And on top of that, speech and language therapists should be delivering therapy to those with tracheostomy and involved in weaning. So again, this gives us permission to be there and to undertake our work. As I said, only last year, the national guidance for those with traumatic injury specifies that these patients will have swallowing and speech difficulties, and that they should be seen by speech and language therapists or appropriately trained healthcare professionals in order to make the right decisions and be involved in rehabilitation. So here we see we've got all this national guidance that is supporting our involvement. Dovetailing with that are the competency guide frameworks and position papers published by our own professional body. And again, I've had the opportunity to be involved in these, and I would encourage and empower you to do the same. So these are the set of rules against which we can measure our competency and our skills. But as we know, practice is not yet uniform across Europe or the world, which means inequity of care. So it's important for each of us to be clear, what is the problem that we are trying to address in ICU? Firstly, and most obviously, is the lack of communication and voicelessness as a result of needing a tracheostomy or a ventilator. And this has an impact on the mental, physical, and spiritual functions of a human being. It removes their agency and their control, and this is a basic human right. The impact of this is also on staff and their provision of care. Our patients can't be involved in the consent process. They are excluded from talking therapies that limit their delirium management. Their evaluation of capacity is reduced, and this may be interpreted as having no capacity. It means that they may experience the unnecessary use of restraint. If needs aren't clear, there may be some misinterpretation of symptoms, which might lead to over or under treatment. Staff themselves often report a real sense of frustration when communicating with these patients. It means that they avoid the patients. And often with good intention, we pretend we understand what they're saying. And this can go wrong when people agree to do something, but they don't undertake it. So communication is a real issue for our patients. Post-extubation dysphagia, again, there is growing evidence. In this paper, Zurcher and his team in Switzerland report an 18% incidence, but more critically, over 80% still reported dysphagia when they were discharged from ICU, and over 60% had dysphagia at hospital discharge, with an excess 90-day all-cause mortality rate of 9%. So if we can prevent this, why aren't we doing it? We are confused by the causes, and they propose that these are due to endotracheal tube trauma, neuropathy, reduced laryngeal sensation, reflux, and breath-swallow dysynchrony. But we should be involved altogether with trying to resolve these issues. This paper by Sarah Wallace shows the mechanical damage to the sensitive parts of the mucosa of the airway. And we saw much of this in our COVID patients when patients were intubated for many weeks. Again, working closely with our ENT colleagues, we were able to find therapeutic options to resolve and manage these issues. And of course, Marty Brodsky's paper back in 2018 also reported an 83% incidence of laryngeal injury as a result of intubation, proposing timely laryngeal assessment post-extubation to prevent the complications. Another key issue in the ICU environment is around practice. And as I mentioned before, that workforce imbalance. We know that there is far fewer speech and language therapists than nurses or physiotherapists or even the doctors altogether. And so that's why we really need to be very clear about what we're doing and why we're doing it. Peter Spronk's study, which I was involved in, was a survey to ICUs across the world in 26 countries. They had only a 19% response rate, but 66% of ICUs said that they did have a speech and language therapist, but only 4% had a dedicated speech and language therapist. So we have a real workforce issue here. And although there was generally good awareness of dysphagia incidents, factors, and the need for assessment, very few had a standardized protocol. This year, we had a survey published from the UK, and we have made great strides here. 96% of ICUs have access to a speech and language therapist, but only 23% are funded. And remember, I said the staff to bed ratio should be 1 to 10. Well, they found that the funded services had one therapist for 30 beds, and the unfunded had one for 157, which is shocking, really. You can't deliver rehabilitation at that rate. We have a list on the right of the range of interventions speech and language therapists were involved in. And as you can see, it was communication, dysphagia, secretion management, and managing trachees. But less than 50% used FEES or FNE for airways. And even fewer used some of the new approaches such as EMST and surface EMG. So again, we need to have those as part of our core work. And really importantly, and we mustn't forget this, the pleasure of food and eating and drinking is so important for our patients. Often to indulge, and sometimes our staff like to indulge our patients by giving them food, which is a really high risk event, but we must engage with our patients around eating and drinking. So what is our role in ICU? What is our superhero going to do? We should be delivering AAC, and this could be across no technology to high technology. Other options include just the simple use of emojis, which are helpful, but also there are specific approaches to getting voice through above cuff vocalization or use of one-way valves, and this should be led by speech and language therapists who understand laryngeal physiology. Saliva management is a really big challenge with our ICU patients. They may be hypersalivating, producing too much saliva, but there is a range of strategies that we can help to resolve this. And I've done this with many, many patients. Dry mouth and thirst is another really big issue. And again, there are ways to tackle this rather than drinking endless amounts of water. Again, we can contribute to this. Tracheostomy cuff deflation is a real barrier, particularly to speech. And I developed this algorithm to try and show our systematic approach to being able to take a cuff down, but also managing the challenges that we are going to be met with along the way. And that there is a method to come back round and to achieve success, which is what happens on that top line. I'm happy to share this, of course. I've been involved in a lot of weaning from ventilator and identified that early involvement and engagement of that laryngeal function really benefited the patients, and that actually we had multiple success with both eating, drinking and speaking, as well as weaning from ventilation with our patients. Of course, we can deliver the diagnostic assessments with FEES, and I would really encourage training for that, as well as video fluoroscopy. But I would say that our practice in ICU using FEES is different, and actually it focuses more on the airway. So on the left-hand side, we've got the skills for swallow evaluation, but on the right, for airway intervention, we actually need different rating scales. The risk is higher. We need to be manipulating the airway in a tracheostomy. We should be doing this alongside our nurses and our physiotherapists, and understanding what airway physiology is like. So I would call this advanced practice. This is different, and we need to recognize and train our staff to be able to do this. Of course, our dysphagia interventions are essential, and these focus on strength and skill training. And I'm sure you're all aware of the whole range of interventions that we can deliver. However, I have to say, for many of our patients, thickened fluids is not a therapy. There are also a range of devices that are now coming online. Electrical stimulation, which I know some other professions are employing, things like phagenics and surface EMG, and also EMST. Again, these are tools that it would be good for our speech and language therapists to be handling and managing. Central to this is teamwork. We need a patient-centered approach that involves all our team in making these decisions. Our role is to optimize what our patients can do. And I've got a list here of all the usual professions that we work alongside. Our dietitians optimize their diet and textures and chart the intake to reduce the feed. Our OTs will help to position with self-care and use adaptive tools. Alongside our physiotherapists, we deliver joint weaning approach, chest clearance and mobilization. Our nurses can support our oral hygiene and communication skills. And alongside our doctors, they can review the medication, nutritional and secretion options, because there just aren't enough of us to be able to do this on our own. And I propose a multidisciplinary dysphagia pathway where doctors and nurses can do this preliminary screening. We can deliver the diagnostic assessments, but of course the whole team are involved in those therapeutic interventions so that we know that our patients will get consistent input that will deliver rehabilitation. So I encourage each of you to take action to develop your own superhero. And here are some top tips. I'd say to my team, show, don't tell. I know we like to show our knowledge by writing lengthy reports, but often an image will be quicker. And our teams generally love to see the pictures and helps them educate and understand where the problems are and how we're going to tackle these. The use of modified diets is well established, but as I said, for many ICU patients, they may not be appropriate. So don't just seem like a food technician. Deliver an intervention, be a therapist, show your skills and your knowledge, and show how we use the information from our diagnostic assessments to plan our therapy. In many cases, we may have to make a decision for nil by mouth, but our teams aren't really inviting us into ICU for that. So I say, give something back to the patient and to the team. Integrate yourself, help them understand how you can add value so that when that patient is ready, they'll be able to return to oral diet. This may be around secretion management or increasing range of movement. Our advanced speech and language therapist needs a whole toolbox of skills, assessments, interventions, and strategies that make your role unique. These need to be evidence-based, and you need validated outcome measures so that you can compare what you're doing with everywhere else across Europe and across the world. If you need to take further training, I think that's really helpful. It validates your skill and makes your practice rigorous. Alongside this, you need to educate. What is your national and professional guidance? What is the evidence for your practice? How can you achieve your competence and grow your confidence? Maybe there are shadowing opportunities or time to spend abroad with other colleagues. You need to collaborate. How can you work together with your team to introduce advanced practice? Is there a complex case that you could use as an example to discuss and reflect and make that change happen locally? And most importantly, you need to celebrate and share your hard work. What you did, what difference does it make? It may take a while to get the change you desire. Perhaps you can invite speakers in, share publications, set up a journal club, presenting at conferences. You can become that speech and language therapist superhero. I've been able to establish international links through my work and worked with colleagues around the world. I've been able to influence the speech and language therapy guidance, excuse me, for our spinal cord injury patients. And this is going to make a huge difference to standards of care. I was also privileged to work for the WHO to set up the package of rehabilitation interventions for spinal cord injury. I have to say, many of the people in the group didn't really believe in speech and language therapy and wanted to leave these out, but I was able to convince them. And then they unanimously agreed that speech and language therapy is a human right and would help quality of life. I've worked with colleagues in Israel. I spent a month there training them up to use FEES in their ICU and really problem solve. And I've been able to train the next generation in Leuven, both last week and last year, and our teams around England as well. So I hope you keep in contact with me. I'm on social media, on Twitter. You can look up my publications on ResearchGate and ORCID, and I'm handing back to you to hear what you're going to do next. Thank you very much. I'm going to stop sharing.
So thank you very much, Dr. McRae, for that very interesting and insightful presentation. So now we have some time for questions and answers. So we can start looking through our chat and see who was posting questions. So the first question that we have is, what is your advice for introducing FEES as a procedure done by SLTs?
Absolutely. I think I've been fortunate. I've been trained with FEES for over 20 years, and I train other clinicians to do FEES. But I think we have to accept that there are two aspects to FEES. One is passing, the technical skill of passing the scope. I think anybody could do that, so it doesn't have to be a speech therapist. But I think the skill that we have is to do with evaluating and looking at what the assessment is, directing the assessment, interpreting it, and making our plan for the intervention. So that is the speech and language therapy skill. So I don't mind who holds the scope. The scope isn't the magic wand, it is us, and it's our decision making that is the important thing. So I'm not protective. I do think we need to work together, but as I say, we are planning that intervention. So it's certainly what many countries do, and I'm happy with that. We only have one person and one pair of hands, so if you can make it easier, that's fine. So thank you.
Thank you very much. We have another question which is related with FEES actually. And this person is asking if the SLT does it independently or with other doctors.
Again, as I say, I think it's useful to look at the skill set that your team have. If you have got somebody else who wants to pass the scope and you don't have the ability to develop those competencies, then that's okay. As I say, I think the speech and language therapists need to develop a high level of skill in terms of interpretation and reporting, and then have regular access to reviews using FEES. So it's not about owning it, it's about who takes the responsibility for what happens next.
Okay, thank you very much. And before we continue to the questions, may I encourage the participants that they can switch on their cameras now, since it is question time, and maybe it can be more interactive that way.
Yeah.
So we have another question. So the evidence for the need for SLTs in ICU and within emergency medicine is clear. However, given lower staffing levels and barriers to further training, how do you feel we, as a profession, can balance issues of the workforce funding the need for emergency care presence versus community presence in the hope for prevention of admissions to hospital?
Yeah, absolutely. I think it depends on the patient group, obviously. I think we absolutely do not have enough staff, and so you have to work smarter and wiser. I think we can argue that we are better value for money in the intensive care by delivering early rehabilitation, but preventing admissions, which I presume is what it meant in the question, in terms of community, particularly for our elderly and frail population, we can prevent admissions, I think that's of value as well. In all of these settings, we need to educate the people who are spending 24 hours managing and caring for these patients, so that they can also build in some of these preventions. So, you know, we are now moving towards looking at risk factors for dysphagia, or, you know, if there are communication or cognitive problems, how can our other staff help to support them? So I think absolutely, we are not going to magically multiply ourselves times 100, but we have to work smarter across together with our other professional colleagues to highlight what they can do, what can they deliver, so that we can use ourselves for our extra special skills.
Thank you so much. May I also remind you that there is also the evaluation form that needs to be filled in. So kindly go to the chat so that you can find the link and fill it in. We've got another question for you, Dr. McRae, and it is about what is your take on the CTAR exercise for swallowing rehabilitation?
Yeah, chin tuck against resistance. I think with all rehabilitation exercises, I think what is valuable is to try and evaluate how they actually change the impairment. So rather than using global exercises for all patients, as I say, I think if you have an issue with base of tongue weakness or reduced higher laryngeal elevation, you need to make sure that the intervention you're choosing manages that. And again, I use FEES or flexible nasendoscopy to actually look at how that has an impact. Again, videofluoroscopy can be useful as well. So if you're thinking of an exercise or a swallow strategy, try and integrate it in your evaluation so that you can see whether it does address and manage the problem. And of course, this is a strength exercise. I think the challenge, of course, with tracheostomy patients is that you have a tracheostomy in situ. So obviously, you can't put more risk on the patients.
Okay, so we have another question. It seems that it is being asked from an SLT student, because this colleague is asking, do you have any advice for an SLT student who would like to go into a critical care environment, as shadowing opportunities in ICU environments are difficult to come by?
Yeah, absolutely. I think, and obviously post-COVID and during COVID, it was very, very challenging to have our students on the wards at all, because we needed to safeguard them. ICU can be quite an intimidating environment, and I've certainly had young people who came to shadow who would then feel very unwell and have to leave. I think do have a chat to speech and language therapists. There are talks, there are videos, try and imagine the environment, and maybe over time, if you can demonstrate that perhaps you've got some skill, maybe even volunteering could get you into that environment actually. But as I say, I think it is very difficult to accommodate hundreds of students alongside a speech therapist in an ICU. So as I said before, if you can give something back, then you may get an invitation.
I think we also have one last question besides all the positive comments about the very interesting talk and presentation. So last one, if I'm not mistaken, because my colleagues are passing on the questions, but I think this is the last one. What is the most frequent problem that is unnoticed, so it is discarded in ICU patients face? The problem is is very visible in this country.
Well, I think all of the issues that we deal with are hidden because they all happen in the throat, in the bit that we can't see. I think communication is unnoticed. I think the secretion problems are unnoticed, and even the laryngeal impairment is unnoticed. So this is almost what we uncovered, particularly during COVID. We didn't really expect to see this level of impairment because, in theory, these patients didn't have a neurological problem, but in fact we found huge issues around laryngeal edema and pathologies. So I think anything that disrupts laryngeal function and the larynx is hidden and unnoticed until perhaps the patient is a little bit more interactive. And in my experience, sometimes people misinterpret it as being anxious when they start to play around with the tracheostomy, whereas actually there is a pathology. So there isn't one thing, but I would say anything to do with laryngeal impairment that is forgotten. I can see someone. Oh, sorry, Danielle, you're on mute. Yeah, I was going to say, I see someone wants me to share my contact details again. Do you want me to put that slide up?
Yes, sure.
And you can read out the next thing. I've lost it now. There we go.
So here are the contacts of Dr. McRae for those who would like to contact her. As you can see, you can either send her an email or maybe reach out on Twitter or other social platforms.
Any other questions, Daniela? I can't see them now.
I don't think so. Well, yes, I think we have one last one. So since we are like a little bit comfortable in the time, I think, yes, we can forward this question. So in your experience, how long do you think it is expected to take an SLP to become FEES trained? Not simply at a theory level, but at hands-on practical terms.
I think that's a really good question, actually, and it depends on how much time you can have alongside your supervisor or trainer. Definitely when I was in Israel, I was there for a month and we did some intensive hands-on training and evaluation of the videos. They already had a fee service being delivered by ENT. And in fact, they felt that they could approach their Ministry of Health to make an argument for being competent and then advance their skills. In the UK, we have quite strict competency and numbers of scopes that you need to do in order to be competent. So I would say with an intensive, with a colleague alongside you, you could probably do it within 6 months, maybe 3 months. I know in UCLH during COVID, I upskilled the team, but we were scoping very, very regularly. So there's a balance between the numbers and that sense of competence and confidence. And I would say you need to work alongside a clinician who can evaluate your skill as you go along. So some people, it can be really quick. And then, of course, it takes many, many years to develop that experience of what you're going to see and how to manage those problems. But don't let that stop you. It's definitely not a race. You've got to really invest in your time. And if you can have a group that you can reflect your practice and develop some inter-rater reliability, that is the best way to really enhance your learning.
Okay, so I'm going to just add the last 2 questions because it seems like they don't want to stop, but I'm going to I'm going to combine them so for you so that we will gain a little bit of more time, and then I guess if maybe there are other questions coming in, we can also suggest the participants to direct you directly to you. That's possible. Okay, so these last 2 questions are: have there been any common symptoms of post-extubation dysphagia noted so far in both adult and pediatric populations? And are the SLPs also included in the WHO emergency group?
Okay. Oh, with the WHO groups, I don't know. They recruit individually, so you would have to go back to the group leads for the WHO work. I think I was recommended by another clinician, so I got involved in that. And you obviously have to submit your CV to verify your expertise. In terms of common symptoms post-extubation dysphagia, both adults and pediatric, again, I think the main issue is around the mechanical impairment to the laryngeal mucosa. And if you remember in Marty Brodsky's systematic review, the predominant feature was dysphonia and also pain on eating and drinking. And we definitely saw that with our COVID patients who had sometimes over a month being intubated, is that the voice problems were the key thing, pain on swallowing, and then dysphagia was a subcomponent, but we could work with that to get that stronger. So that was more of a disuse picture rather than damage itself. And again, I can't talk to pediatric populations. I've only seen very few. Again, that isn't my specialism. So I would defer to other colleagues around pediatrics. Yeah, that was the two questions, wasn't it?
Yes, that's it. So thank you very much, Dr. McRae, for your time, for accepting our invitation. It was a great pleasure having you here. Thank you, everyone, for joining us this morning to celebrate European Day of Speech Language Therapy. As we're going to close today's event, may I kindly share with you again our upcoming ESLA webinars for those who maybe have missed the initial part. So there are 3 planned webinars during the remaining of the year. So it's one on 22nd of June, October 5th, and November 30th. Keep on the lookout on our social platforms so that you can remain updated and informed. Also, may I remind you of the upcoming 12th ESLA Congress of Speech and Language Therapy happening next year in Belgium. More details are coming up. So again, keep on the lookout, eslacongress.eu. And also, do not forget to fill in the evaluation form so that you can receive your certificate of attendance and also to give us feedback on today's webinar. On behalf of ESLA and on behalf of ESLA Speech Language Therapy Day and Webinars Task Force, I thank you all for joining us, and may you have a very good day and weekend. Thank you, everyone. Bye.
Thank you. Bye-bye.